For the next session, I would like to call upon our speaker, Dr. Antarakia Borodai, and chairpersons, Dr. N. Madhu, consultant surgeon and medical director of Chaitanya Hospital, North Parvur, Dr. Taruni Nagambam. She runs a diabetic clinic for past 35 years and is trained in geriatrics.
Good afternoon, everyone. In this era of superbugs, because of the overuse and misuse of antibiotics, we are facing a lot of problems. Multi-resistant organisms are growing. To talk on the subjects, we have got Antarakia Borodai. She'll be talking on the subjects. And welcome, madam.
Thank you, sir. Thank you so much. Good afternoon to everyone, respected chairpersons, and my seniors present here, and my colleagues. First of all, I would like to thank Dr. Ashokan, Shajesh Ashokan, sir, for giving me this opportunity. And I would like to applaud the GSICON Kochi chapter for organizing such a wonderfully organized conference. Everything is managed so well till now. And of course, the academic whatever we've got till now, talks and everything are wonderful. It's really pleasure to be here among all of you. So let me come back to my topic. I'll be speaking on multi-resistant antibiotics in elderly, the causes, the strategies, the reasons, and what all can we do. I'll be covering all these topics in it. So, as we know, antibiotic resistance, it's becoming a global concern, especially in the vulnerable population, such as the elderly population. This problem is basically more widespread because of the availability of over-the-counter medications, the excess use of antibiotics because of the recurrent and continuous infection process that keeps on happening in elderly. So an elderly keeps on getting admitted, keeps on getting antibiotics, and it becomes a resistant pattern for them, and resistance starts developing. Elderly patients are already physiologically vulnerable. So when they are exposed to this kind of scenarios, they are be it infection or be it any kind of illness, be it urgency, emergency, they are at a heightened risk for infections due to MDROs. So, a study conducted in 2023 by the ICMR showed alarming levels of resistance in bacteria such as Klebsiella, E. coli, and Acinetobacter. Klebsiella showed a 27.3% resistance to carbapenems. E. coli showed a 72% resistance rate to third generation cephalosporins, which we normally advise in their treatment. Acinetobacter had over 50% resistance to carbapenems. So, such resistant organisms are more likely to be encountered because of the increased hospital admission due to recurrent infection, comorbidities, frequent antibiotic use, even the over-the-counter availability of drugs and antibiotics which the elderly patients end up taking. So this is a graphical depiction of the percentage of organism that has developed resistance. First and foremost is the ESBL E. coli. As we know, E. coli infections are very, very rampant in elderly age group. This is followed by MRSA, by Acinetobacter, C. difficile, etc. and goes on. So if we go into statistical insights, a study conducted in a tertiary care hospital in Delhi in 2021 showed that 48% of patients with bloodstream infections were infected with multi-disease resistant organisms, primarily gram-negative organisms, like I have already discussed with you. Another study in another surveillance data from Tamil Nadu in 2022 revealed that among elderly ICU patients, 70% of ventilator-associated pneumonia were caused by multi-drug resistant Pseudomonas and Acinetobacter. Another multi-center study across India in 2020 reported a high prevalence of ESBL producing E. coli in urine samples. So when we come to the risk factors, which contribute to the development of resistance, first and foremost important factor in elderly population is immunosenescence, which is happening in the elderly age group. Due to the deficiency in T cells, B cell activity, the phagocytic activity goes down, cytokine production goes down. So hence, if an infection occurs in this age group, it's very difficult for them to take control of it, for the doctors to take control of it at a primary level. You may need aggressive treatment, you may need hospitalization. Polypharmacy, as we know, is rampant in this population. It is inevitable because the elderly are suffering from multiple comorbidities. But in this, one point can be highlighted: the usage of proton pump inhibitors. Now, proton pump inhibitors has a certain period of action. If you keep on using it for a prolonged period, it can cause most commonly dysbiosis, which increases the susceptibility to resistant infections. Then the occurrence of sarcopenia, malnutrition, which is linked with immune function, immunoglobulin production, it decreases. Then the other conditions happening commonly in elderly is the frailty status. There's decreased mobility, which can cause bed sores. Once a bed sore starts, you are bound to start antibiotic in that patient, and it becomes a cycle. Then another thing that we notice very commonly is the cognitive impairment. Cognitive impairment plays a very important role because a elderly person presenting to a doctor or a physician or a geriatrician comes with an atypical presentation. You are not able to diagnose the disease or the process involving the disease. So we end up giving them broad spectrum antibiotics. We end up giving them unnecessary antibiotics, which as a result can cause the antibiotic resistance. Of course, multimorbidity, as we know, this is a status in the elderly patient. So it requires, because of the multimorbidity status, they are immunologically on the poorer side. They end up with a lot of infections. They end up with a lot of hospitalizations. They require a lot of OPD visits to doctors. Hence, we as treating doctors want to make it comfortable for them, want to get them cured. And even if we don't advise antibiotics, they end up going to a pharmacy and taking over the counter antibiotics and taking it. Frequent hospitalizations, long-term care facilities, residents, which is not that common in here. It's more common in UK and US. But the residents in this kind of facilities have a strain of infections going in and around them throughout the year, throughout the days, every single time. One person starts an infection, the whole unit gets infected. And to control it, antibiotics is the only powerful thing that can be given. So now coming to the strategies to combat this resistance. First and foremost is novel antibiotics. Novel antibiotics is a group of antibiotics which is kept in reserve when the regular antibiotics are not working, are not giving the desired effect, or the patient's culture specimens have shown resistance. Then we shift to this novel antibiotics. I'll come to the antibiotics in the later on slides. Then the bacteriophage therapy. These are basically employing of bacteriophages or viruses which infect and lyse the bacteria. It targets the antibiotic resistant pathogens. This is very much useful in Clostridium difficile infections in elderly patients, which have shown 70 to 80% of relief or improvement. Then comes the antivirulence therapies. Now these act on the production of toxins and biofilm formation. That is the main mechanism of a virus causing the infection or carrying on the infection cycle. So these therapies straightway targets on it, thus stopping the cycle of the infection. So in this also there are a lot of drugs and important factors which we notice. Then probiotics and fecal microbiota. Probiotics like lactobacillus and Saccharomyces are very, very important for maintaining the gut bacteria, healthy gut bacteria, which we see a lot of incidence in CDI patients. So that, to bring back the balance, we need the probiotic support. In CDI patients, also a fecal microbiota transplantation has a very good effect or outcome. There are a lot of vaccines also which are getting developed, has been developed for bacterial infections, so that the infection does not happen, so that we don't need to give them antibiotics, and hence the resistance cycle does not develop. Now, antimicrobial stewardship programs, basically these are initiations, rules, regulations which need to be implemented regarding the usage, dosage, time, duration, etc., availability of the antibiotics to the patient. Then the most important part of all of this, the very first step is the advanced diagnostic techniques. Once we are able to diagnose the disease, once we are able to figure out the resistant patterns of the antibiotics, figure out the proper sensitivity to particular antibiotics, we can target the infection with that particular antibiotic and we can stop the antibiotic resistance development. So, coming to the novel antibiotics which I had mentioned, these are some of them which have come across. The first two, Tixobactin and Cefiderocol. Tixobactin is still in the clinical trials. Cefiderocol is stuck in the licensing part, but they are very good. They're effective. First, Tixobactin is effective in gram-positive organisms in MRSA, VRE. Cefiderocol is more active in the gram-negative organisms in Pseudomonas, in CRE, in ESBL. However, all of these drugs have a potential of nephrotoxicity. So we need to be very careful when we advise this medication, especially if renal impairment is there. Dosing has to be adjusted. However, we need to be very, very careful in this. Third, which is plazomicin, is available. This is more active in CRE in Pseudomonas. Tazobactam, Avibactam, all of us are practicing meropenem in our clinical practices and we are getting a good response, compared to the other older antibiotics. Muripividin is a topical antibiotic which was started for Acinetobacter infections. Among all these, plazomicin is available in the market. Tazobactam, Avibactam is available, meropenem is available, Vaborbactam is also available. So now I've come to some research articles. I found very interesting research articles regarding the multi-resistance or antibiotic resistance or multiple drug resistance in elderly. First is a mortality burden. It was a retrospective observational study conducted very recently. It showed a mortality rate of 13.1% in patients, out of which 2 to 3 times were higher seen in infections with multi-drug resistant or extensively drug resistant in Klebsiella and in Acinetobacter. Next, this study is also very interesting because it covered basically the livestock industry or the feed farming industry, which uses antibiotics in their livestock for promoting the health and protein enhancing and all. Hence, we as consumers end up taking those antibiotics in the whole phase of their marketing and selling and all. So this article covered that emergence of antibiotic resistance due to the excessive use of antibiotics in medicines and feed additives. They have found there is excessive unregulated use. There are no laws, there are no regulations. They're using any kind of antibiotic that they get their hands on. They don't even know which antibiotic has what kind of effect, what are the consequences, what it can do. So this can be improved by mass awareness. The people in livestock or feed industry, they should be taught about the antibiotics, what they can do, the harmful aspects of it, and they should be advised to use or not even to use also. Next article was antibiotic resistance in older adults with a special focus on the Alzheimer's disease patients. Now, in this, of course, there is an increased antibiotic resistance that they found. However, because of the complexity of resistance patterns, now Alzheimer's disease patients, it's very difficult to analyze their outcome. It's very difficult to have a proper examination of those patients. So it was difficult for them to understand how much of the resistance were there, what kind of what kind of signs and symptoms were they experiencing, what all were they presenting with. Next was a multicentric longitudinal study from 2017 to 2022. It showed a significant increase in resistance of meropenem and imipenem to Klebsiella and Acinetobacter. Now, carbapenem resistance in hospital-acquired infections preceded that in community-acquired. Among all of this, cefotaxime resistance emerged as a potential early indicator for emerging carbapenem resistance. Also, that can be used as a novel surveillance marker. This is one point which is very important in researches in future. Next is another study, which was approaches to multi-drug resistance organism prevention and control in long-term care facilities. Now, like I said, in long-term care facilities, there is always a presence of infection among the inhabitants. So it highlights the effectiveness of interventions basically in this kind of facilities with proper hand washing, isolation, cleaning, sterilization, etc. So for all of this, administrative engagement is required in these kind of facilities. So when it comes to implications in geriatric healthcare, very first thing, obviously there is an increase in morbidity, increase in mortality. There are reduced treatment options because already the patient has become resistant to so many antibiotics that you end up using the novel antibiotics even before it's required. Then antibiotic stewardship challenges in geriatrics settings. Like I said, an elderly patient will not present with only a one particular infection. Elderly patient can present with multiple infections at one time, can be a lung infection along with a urinary tract infection. So in that kind of scenarios, we fall into a dilemma, what antibiotic to start. And if resistant patterns come, you need to match both the resistant patterns, and it becomes difficult and gruesome for us doctors to start it. Surveillance and reporting. Right now, ICMR and Research Network, that is AMRSN, are doing research in all this and reporting, but it is not age specific data. We as geriatricians would like a little bit more of age specific data because it does differ when you compare an adult population with a geriatric population. Stringent antibiotic policies. This is very much required. It's the need of the hour right now. This has to be formed in regulating hospital antibiotic usage in OPD, in IPD, everything. Diagnostics needs to be improved. It has improved a lot. However, more improvement is expected because once the diagnostic improves, the treatment process for us becomes easier. The consequences, the side effects decreases. Then enhancing infection control practices, hand hygiene, sterilization, isolation protocols in hospital, all of these are the parameters that should be properly followed. Public awareness campaigns, these are very, very important because we as doctors, we do discuss among ourselves the need of this, the importance of that, etc., etc. But it's the general public who also need to understand the antibiotics, what kind of antibiotics are there, what does an antibiotic do, how does it work, how it can affect their whole system, how it can affect the daily regular activities and all, what they should not do, how they should do it, etc. So this is a pictorial depiction of the whole topic. Multi-drug resistance, like I said, the risk factors, most important is the immunosenescence, polypharmacy, frailty, malnutrition, multiple comorbidities, etc. Organisms most commonly that we get to see is E. coli, Acinetobacter, Klebsiella, MRSA, VRE, which as such the outcomes are prolonged hospitalization or repeat hospitalization, which can further cause post-hospital syndrome, deconditioning, etc. A lot of symptoms can happen. The need for broad spectrum antibiotics because it becomes a circle. Once a patient is admitted, you advise antibiotics. Next time, again, the patient may develop resistance, another antibiotic, third admission, another antibiotic, and it just becomes a circle for the patient. There are increased complications, mortality, health costs as such to a person, individual, to the country itself. Solutions: novel antibiotics, bacteriophage therapy, antivirulence therapies, probiotics, fecal microbiota, vaccines, antimicrobial stewardship programs, and advanced diagnostic techniques. These are the best solutions for it. So, in conclusions, it is a critical challenge in elderly healthcare right now. It requires a multifaceted approach, including enhanced surveillance, better antibiotic stewardship, and targeted healthcare interventions. By prioritizing these strategies, we can mitigate the risk of resistance, improving outcomes for the elderly population. These are the references. Thank you so much for patiently listening to me. Thank you.
Thank you, Dr. Bordoloi, for such a thorough and insightful talk.
Thank you.
And as such, antibiotic resistance in the elderly, it is a critical situation now. And as we know, most of the studies are being done in the general population and in the children. And then most of the research work, as we have been discussing in the past, also is being done in other patient groups. And so it is not actually not done in the geriatric group. and so it is the right time and for to look into the matter. And now the topic is open for any queries from the house.
Wanted to ask whether a Septran, Bactrin type of drugs or even plain doxycycline, how they should be used in such situations. Because otherwise the usual trend is straight we start with one aminoglycoside, third, fourth generation cephalosporin. But at least I have found that in some simple infections, doxycycline oral or our old time sulfa Bactrim, they are also useful. So what is your opinion on that, madam? And what is the stand taken by ICMR on reusage of some old drugs so that the resistance doesn't grow?
Thank you, sir. I'll take the question, ma'am. Okay, when it comes to simple infections, of course, we have antibiotics available, and doxycycline is one such antibiotic which can be used in lot of infections, undiagnosed, unknown, even as a first liner also. But when it comes to complicated infections such as respiratory tract infection or UTI complicated, and if your culture studies show a lot of resistance, then you you are bound to start the novel antibiotics or the reserve antibiotics that we have, because these antibiotics on the primary level will not be able to suffice or treat the infection as such. So in that kind of a status, the novel antibiotics has to be used. And the novel antibiotics, the first that I said, this is in clinical trials and all, they have very less resistance till now developed. In fact, vancomycin, when it was started, it took almost 30 years to develop resistance to it. So these novel antibiotics is just in the starting threshold. It's going to take some time. These are also going to start developing resistance. But right now, these are an options for us. Every year, every second, third year, newer antibiotics are coming up accordingly. Thank you.
Thank you, everyone. So now we close the session.
Yeah, thank you, ma'am. Thank you, chairpersons. So
Thank you,
I
sir.
would like to request you to collect your memento from the faculty lounge.